So friends, before we come to it, the secret of Archana's success is that she's a marathoner. She does wonders every day today and suffered a fracture, and if I'm down on that, I'll make it crisp. I've spoken here before. I belong to this IMA West, and it feels very good to be back at Mumbai. There's a small piece of paper which I would like all men to carry home and should score yourself. My phone number is visible to you, so you can always send me back the score. This is important because when men age beyond 40s, 50s, this is the most important scorecard compared to all your matriculation certificates and MBBS certificate. This will actually matter, and I'm going to speak a little bit on that. I think it's crisp and fast, but let me mic this before the pre-lunch session and last respected speaker who comes in. We're talking about the most wonderful thing that I saw in today, healthy beginnings, which are our foundations, and to hopeful futures, which is our journey. To take this journey forward on a Sunday afternoon on a WHO Day celebration, it's great to be speaking on attempting newer eras in uroenterology. And friends, the subject is huge. When you dial U for urology, you find A to Z. From what God forgot and gave congenital anomalies, to what graceful aging brings about to all of us, which we miss out completely, to one fine day we'll end up in emergency. These subjects is what I deal with 24/7. I just finished a 3.5-hour round in Kotilarin Hospital and came in time here because all of them are admitted out with issues which happen, and what is the great partnership that you and I do is about the teamwork that we connect with. So we look at each of these subjects in this era 2025. But today's short and crisp in 15 minutes. Let's respect and salute you because you connect the dots between the entire IMA and the society in this part of the country. And I aim to, in the next 15 minutes, look forward to changing the headlines from tomorrow. That means in the subjects that I deal with, I look forward to the patient should say, I love my doctor at IMA. So you all are urologists anyway. You deal with incontinence, deal with prostate, deal with UTIs. But we just go forward in a little state-of-art business that I'm involved with the Kotilarin Hospital. For all of you, bringing you greetings, bringing you sunshine to you and your families, and pink of health that should happen. We follow this motto, every life matters, and today, assembling into 16 years at a Kotilarin Hospital. It's a story to be again being here, stepping into this era with a lot of promise to partner and take it forward. So when I talk about partnership, I need to understand that we need this. We need to be partners. I cannot really do what you do. You do A to Z. That's the big salute to all of you in IMA. You do everything. You do malaria, you do filaria, you do UTIs, you do diabetes, you do awesome. And you attend these kind of workshops, which I also need to come and sit in the audience. But to me, this is what the journey is. About the evolution of mine in CMC of Vellore, and then Ramachandra Medical College, JIPMER, and the experience I amassed in the last 24 years across the globe in 11 passports I traveled across. The evidence, expertise, expectation that we need to match and endure. I have been asked not to operate for 1 month with my left hand corner. So I enjoying this with this. Last 24 years, the wall across my room has been filled up with subjects which matter to me. Everything right from male incontinence, which is iatrogenic, which if I operate and somebody gets incontinence, is a male incontinence compared to female incontinence, which is a gift or sad pelvic health changing event. And therefore stress incontinence come later. And all this is a part and parcel of life and many more. So first we touch quick some new indications. Look into that because that's a part of requirements. It can be required to anybody. Me, my family, you, your family, your neighbors, your patients, anybody. Look at warding dysfunction, not able to pass urine well. That means the culprit either is the bladder or the culprit is the outlet, which we all blame the prostate. Warding dysfunction can come in many ways. But what's new and what is important is for you to know. I think I revolutionized this in 2008-9. We stopped for 10, 11 years because the company Medtronics closed this completely and took away this subject for quite some time. In 2021, we brought back the subject at Kotilarin Hospital, and close to around 29 to 30 patients have saluted and got a gift of life in terms of these 4 indications. Refractory overactive bladder, refractory warding dysfunction, or the hypertonic bladder, which I'll talk, refractory chronic pelvic pain, which no medicines, injections, epidurals can treat, and refractory fecal incontinence. All that it does is neuromodulates the S3 nerve. By a small prick, I'll show you in a short 30-second video, and the word changes thereafter. And it's like a pacemaker. See, if I have this pacemaker in my pocket, imagine this is what I implant. That's a pacemaker in its silver color, which I'll show you. And that goes as a battery in the region of the gluteus, and that works for 12 to 15 years now compared to something which was 2 to 5 years in the past. So fecal neuromodulation is now free from bladder and bowel issue. It comes with a cost. It all comes with a cost because it's all tardis rolling across the country and the world by Trump. This is also made by America. Indians don't make it. So practically only the receiving end. So what do I do when I do pacemaker in the pelvis? Looking into urinary tract dysfunction and bowel dysfunction. It's about in the operating room trying to find that S3 foramen and actually take a needle there, modulate that nerve, fix it with a pacemaker, and that's what we do now. If you find it, you'll find that what I'm doing is I'm just finding the right location, the C-arm, and placing that with the minutest of detail. It takes me 15 minutes, but I started doing it when I was doing 2 hours into one case. And that's the way we modulate it, look at the topography of it, and finally look into placing the pacemaker in the field. Which means 2 weeks after we place the time lead, we go back to the operating room and implant that important small lead, which is about placing it around. So that is how it is. So that gets implanted in the gluteus. It works for 12 to 15 years like a battery. And modulates the bladder, the bowel, the pain, the nerves. It's a magic which I probably never thought till those patients get completely transformed from fecal incontinence, from urinary incontinence, from hypotonic bladder. And I continue doing a little bit of awareness on this all the time. This was a recent week and we put forward as much awareness and people to come. Friends, let's quickly touch into something else. Prostate health, which is probably required, and therefore please carry the IPSS symptom score outside. Which means that I don't treat the size of the prostate. I treat the occlusion of the prostate. You can see the occlusion is what needs to be matter. The prostate could be 20 grams or 200 grams. My age could be 40 or could be 80. It doesn't matter. What matters is the performance through the urinary passage through which we could paint on the wall in yesterday decades, and now probably is going down. It's only because of the occlusion of the prostate occlusion. And this is unfortunately ubiquitous. All male will go through it. So none of us will escape it. No Modi, no Bachchan, no Pandey, no Mahapatra, nobody will escape it. All will go through it. It could be in 40s, 50s, or it could be 80s and 90s. Sadly, why do we allow it to happen to that level? It's a question today for all of us to wake up. The prostate is undergoing a change. Like my black hairs are turning grey. I won't be able to reverse my age from 54 to 44 anymore. That's called the ECG of the bladder. No cardiologist and no physician in this august audience who treat a heart without an ECG. So why on earth does anybody treat urology or prostate issue without the ECG of the bladder called the uroflowmetry? Close your eyes when you go and pass urine. The fall is not that far as well. It is gradually going down. Can we reverse it? Perhaps yes. If we don't reverse it, what happens is to the effect on the bladder. That's a good uroflow. I would look at all of you coming one day as guests and do your uroflow and score yourself. Good uroflow, bladder increase completely, residual level is 20 ml, 10 ml. This is better than the ultrasound where you only do an ultrasonography. I don't know what you do in the urinary bladder toilet, but you come back and the bladder is empty. So are you passing urine like this or are you passing urine like this? That means you could empty the bladder by passing drop and emptying it till the end and wait for a long time. Or you could empty in a good flow. So what actually happens is, come again. Oh, that's fine. So this is an important stuff that we need to know. The flow pattern, the flow that was so great in the past actually goes down for all of us, men and women do. Women don't have prostate, but they have got urethral changes happening. So the uroflow, which was like peeing on the wall, is gradually going down. If you don't believe it, come to my outpatient department. Just go and see my technician Ganesh and do a uroflow. Don't need to do anything. Just walk in full bladder. Do it for all men, women after 50s, 60s, menopause, changes around. Imagine this is a real-time story. His bladder is holding so much. That real-time performance, different from performing at home. हर कोई घर में पास होता है, जैसे ही exam hall में आया fail हो. So we need to take it forward to the next level. So that is so we do a urodynamics to prove this, and this is what you treat. You don't treat the prostate. You treat the effects of the prostate. The effect of prostate is bladder outflow obstruction. You may also attempt to give some dutasteride and shrink the prostate, but you want to treat this. And this can be identified in a patient's language and by the score. This is very important IPSS symptom score that we should take it for. So friends, if we don't treat an obstruction where the bladder is shouting, the blue line is shouting to the sky, kholo, 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 and we're still busy giving Urimax and Serodosin, I think we're doing a crime to the whole world. All men will age and will have a bladder which may turn weak. And that is the end of it. So look at this important slide, which is a wake up to me to every day on my project called Save the Bladder. Look at this. Impact of BPH on bladder health. That means this bladder continues to suffer as a result of, so this bladder is suffering. There is trabeculations developing in the bladder. What looked like a pristine, normal, healthy virgin bladder is going through trabeculations and finally saculations around. So this is what is happening to this bladder. So bladder outflow initiates physiological cascade leading to changes in the bladder and the lower urinary tract symptom. Left untreated, these changes may become irreversible. It will never come back again. While medical therapy may alleviate and slow down the progression of symptoms, which is what you and I and our patients are happy with, they find a transformation, BPH drugs do little to address the bladder outflow obstruction. Nothing happens. So for decades, their polypharmacy contains the drug Urimax or a number of medications around. Either surgical disc obstruction may be justified to preserve the bladder health and to optimize outcome. Because finally the bladder deterioration is the end result. That means once I said 55 cannot be 45. So we are ready now with bladder outflow obstruction.
to match the expectation of individuals. And there are what is required is important. Most men come in 40s, 50s, and 60s and want their ejaculation to be preserved. If that is what it is, then I'll end up doing close to around 2 to 5 every month ejaculation sparing TURP. That means a TURP where a man doesn't lose an ejaculation. I'm not going deep into it, but just to show you that it's just a TURP where I preserve the ejaculatory hoods and it works in our favor. We leave that and go to what is required for you and me to know. I've spoken on this platform on this subject, but I want to wake you up that a prostate which is occluding and causing all the symptoms of obstruction can just be disobstructed without any incontinence, without a stricture, without a major kind of a worry of bleeding and this and that. Most of the patients in the United States walk back home the same day. I hold back people for a day, not for revenues, but to hold back to get their catheter the next day. So that is disobstruction of a prostate by just applying the staple clips that I talk about. Just save this plate now. Have a look at this. So this is what we're doing as cystoscopy, and this is what we do. That's an animation for you to show that we go into the bladder, and this is the prostate which is occlusive. I'll just open up the prostate. So you will see that when I come back, this is the real time it takes, the real time. That's the real time picture out there. But have a look as to what we are doing. We're just opening the prostate as if you're opening or stapling the prostate away from the occlusion which was happening out here. And that's absolutely new either. This has been in the United States for the last 12 years. I saw it in US, I came back here, I did, and I'm glad we're doing 1, 2, 3, 4, 5 per week now. The second case tomorrow is Mr. Vagasia from Surat, who's undergoing this. He's only 41, has taken medicine for 4 years. No result, he changes medication. Tomorrow morning it could be perhaps the first or second case where we do this. I have looked at my operating times on this, close to 15 to 17 minutes overall, entry and exit. Just you put those 4 clips on the jaw. So you can see that the occlusion has already been reversed. That part has been disobstructed. I disobstructed, disobstruct that. How easy it is, I'm sure all of you. It's a technical job. It's no more expertise in carving the prostate, the niche areas that I used to do. It's all about opening the prostate. I'm sure technical staff can do it. It's all about finding the right location to be opening the prostate. So when we do this, continue on the other video too, to show you the real-time prostate, which is quite occlusive in my operation theater. I go in and exactly place the same time. So whatever you see the animation, you see the real time. You all see that this is a device being used, which is a device that is used for each patient. I go in, I just clip here, clip here, clip here, clip here. And then we probably could be on medication, but this is not for everyone. There are specific indications for each of these.
Yes.
And this is absolutely new era, believe me. I mean, you walk out of an obstruction which was troubling you, bothering you, you took medication, and you're good enough right now with an obstruction relief completely. So that's what the clip is doing. That's where the relief is. So the relief is as good as a passage completely. So we move on this, and look at that. There are patients who deserve that kind of disobstruction to the prostate. And this is a huge unmet need in society. Unless there is bleeding, pain and cancer, nobody would go to hospital. They will all manage themselves at home. That's the reality. Unless there is a little wake-up call, and therefore the wake-up call is about good news issues that we continue creating across the country and putting some Q&A to improve quality of life of not only the health, but also the bladder. The bladder's health is so important, and there is a huge repeat amount of evidence I won't go in. So I have only 4 indications. Otherwise I will do TURPs and HOLEP and all. Young men and needy and need to preserve ejaculation erectile functions are those 40s, 50s. Can't give them medicine for 2 decades of 2 crore rupees and continue to suffer. Continue the progressive symptoms while on alpha blocker therapy, which will end up giving refractory LUTs, no improvement. How do you know the improvement? By the test, the ECG of the bladder called the Euroflow. Patients with comorbidities like cardiac, neuro, and very high risk for anesthesia where Archana and team will not allow me to operate. Very high risk of Pandit, please don't take him to OT. I can still take him to OT under local anesthesia and open the prostate, which I have done for a umpteen number of patients who are all sitting on my YouTube channel thanking me for this. And finally, patients on catheters and failed trials of warding. In a past era, we used to put suprapelvic cystoscopy and people used to carry. 55,000 people in this city have got SPC. They have a catheter from the tummy, they're happy about it. But we never gave them a urinary passage here. So just for those prostates which are in that age group only 30 to 80 grams, big ones. We can't really staple them, it can be expensive. But for larger prostates, what do? I do this. I do a lot of robotic prostate cancers per week. But this is benign prostate removal robotically. That means you go through the abdomen, and that's the prostatic fossa through which I have brought the prostate out. The capsule is intact. And that's a huge prostate of 250 grams, which has been brought into the abdomen and will be removed. In other words, I've not touched the urethra. The urethra may be narrow, tight, don't want a stricture, don't want incontinence. So everything has happened. Instead of removing the entire prostate, the adenoma is being removed, and these are all glands. Now 19 of such cases in 2024 and 4 of them in 2025. are all continent. Nobody has a stricture, nobody has injuries. That is the catheter which is sitting in the prostatic fossa which you saw there. And that's the entire prostate just come out. Except the capsule part, which is also removed in cancer prostate, that I do one tomorrow at 8 o'clock at night. But this one is something which is important for us to be aware that we prevent incontinence, prevent stricture, prevent things happening. So friends, the whole motto here, before I come to the small last part, is about age, need, expectations and timing. Men from 40s to 90s, suffering from urinary health, taking the wonder drug called Urimax, but a stitch in time can save them. We sometimes do this also. In other words, I run this important project called Save the Bladder. The bladder cannot be reversed at all. Nobody can reverse the bladder, not even he upstairs. So treatment delayed means bladder lost. Once bladder is lost, we are lost. Now imagine somebody undergoes this kind of a situation as a male. Now male incontinence sadly is not uncommon. It's iatrogenic, that means given or gifted by a urologist. Either by a prostate surgery or by unfortunate trauma or by a radical prostatectomy. So this is one man who came from Delhi, Mr. S. And he finally got his, so he was standing and peeing urine and leaking urine all the time. We implanted him this new era sphincter which he can manipulate and can pass urine. So that's his new era sphincter. So this is the first of the case in the country which we did at Coquelin Hospital as a demonstrative workshop. Now he's passing urine rather than leaking urine continuously. He's dry, no diapers. He's thanked multiple times, but I said that's my job. I need to probably look at pelvis and perineum and make people healthy. So he's now passing urine. He had gone for a prostate cancer surgery, but now he's dry incontinent. And such 7 patients in the last 2 months have turned dry only because we spread word like wildfire all around. But the last part of this talk is about RIRS. We all know that Needy and Cystone and all exist in this world. They will never go away. More and more brands will come. But what happens to these small stones? The only true natural history of a stone, either it will grow and become big and become a staghorn, I do a PCNL, or they will fall down and cause a ureteric colic. So this patient is equal to 1 stone blocking here, but 3 more stones here. 3 more patients, and accordingly here. So we need to wake up to this phenomenon that how long will Needy work in a patient who is equal to 1, 2, 3, 4, 5 patients. So those multiple small calculi will grow slowly and obviously not give pain till one fine day when you are on your holy celebrations and the patient has a fall. So it is important for us to look into the growth, and this, after this is the metabolic workup. Why is the patient forming so many stones? So friends, today like the flexible scopies you have, we have got the flexible scopes. We can enter into any calyx in the world and can bring about a complete clearance. So this is something which we continue doing now, and it's all about getting into the stuff, clearing it, completely clearing it up. This was before being used for seafaring and airfaring industry because they were all grounded. The pilots, the air hostesses, the sailors and all those people. But now, the last part for you is the medical part. You all know the normal physiology of bladder is making you allow you to sit here, otherwise the bladder could be overactive. An overactive bladder is a common phenomenon where you run, go again and again, sometimes leak urine and wear diapers. And this is something which the drug that you should use is called Mirabegrol. It comes in many names, like 25 and 50 milligrams. The issue here is it takes care of the bladder thoroughly. It's something which does not bring about changes in the mouth and constipation, but the new thing is the tips and tricks I've passed in before too. It's about if you have a lot of urgency, start with sulfenacin in the morning at breakfast. If you have a lot of frequency, start with Mirabegrol, but there's not such a patient, such ideal. Most of them come with urgency, urge incontinence. Start with a combination of both of them. Look at ultrasound and follow them up. So that's how a medical management can become much more wonderful than ever. Those who are very refractory and undergo urodynamics and the urine is leaking continuously during the filling phase, for reasons of it, we normally give a botulinum toxin and inject botulinum toxin into the bladder. This has always been there, but the doses have been revisited. And finally, salute to all women in the world. The female urinary incontinence is sadly a very silent menace. The amount of the news that has spread around why do women live with incontinence and why don't they leave incontinence, it's about them living with so much of tough life in their evening of life or in their mature years of life. We can give them laughter the best medicine by putting that mid-urethral tape. I still do 1 to 2 per week. I wish I did only that and made all women confident in the world and gave them laughter that they can laugh. Friends, modern patients will always bend you. They will come late, and they'll bend you like Beckham in urology and endology. So the last slide is about the man's thing. When men get Peyronie's disease and can be straightened up by the surgical workshops I do. Similarly, the penile processes has done wonders to a lot of men who are diabetic, who are refractory, who are injured, who have got all issues around. And that's the kind of man who actually gets an erection, which is good enough for him because he had failed all erections in his past. He has got injuries, trauma, road traffic accident, and that's the penile process which can be bent. He's capable in the bed into a powered position. And similarly, somebody who's diabetic, and all diabetic men undergo changes in eyes, changes in kidneys, nephropathy, uropathy, cystopathy, and erectile dysfunction or microangiopathy. So friends, these are all wake-up calls to phenomena which is missed out. There are huge indications for these kind of stuff that I continue to do. But as I salute you and give you a big thanks, every life matters in all these subjects that I continue to do around. It could be reconstruction, it could be robotics, it could be all that. So friends, thank you again for giving us an opportunity. Today's Mikey Oak is just yesterday's nut that showed his ground. The subject that I want to touch again before I leave is an emotional subject. God forgets when He sends sometimes girls down. 1 in 5,000 women is born with a phenomenon called as MRK syndrome. This coming week I was supposed to operate 3 girls, all 3 robotically, where I would give them a new vagina. I've been asked to hold back these only because of my injury on the left hand. But this is how I create new vagina for women who are born without uterus and vagina. We have crossed 51 numbers. So when I crossed 50, I took 2 days of break to reverse myself and say that sometimes God forgets when He sends girls down. And these girls are not uncommon. They search me from all over, coming around, and we create a completely new vagina, which is a sigmoid vagina where she's capable as a woman. She can partner a man, and she's not an incomplete woman anymore. Friends, I come to a close, talking about impossible to possible, finally treatable and curable, and we can together. We have done it together multiple times over the last 16 years, thanking you too. In all those subjects that we deal with, a lot of new era has arrived. I just wanted to keep it short and simple today. But the challenge is a daily affair when the patient comes late, and we continue to do it. Thank you so much.